Hello everyone, this is Dr. Gopi. Today it is session 5 of ICU Nursing Orientation Program. The topic today is patient safety regarding the patient ID, patient files, pressure injury and restraints, and etc. As per the quote from Hippocrates, first do no harm to the patients. The sixth International Patient Safety Guidelines or goals or JCA recognized international patient safety goals now embedded in NAVH 6th edition as well. Memorize them. They show up on every audit. The identification of patients correctly. Two identifiers, name plus UHID or date of birth. Never use the room number. Improve effective communication. ISBAR technique for handover. Read back for verbal or phone orders. Safety of high alert medications. Look-alike, sound-alike medications, concentrated electrolytes, and opioid safety matters more than any other drugs. The correct site, procedure, and patient surgery. Marking the surgical site, timeout, and surgical safety checklists are essential these days. Reducing the hospital-acquired infection risk by utilizing the hand hygiene technique and infection prevention and control bundles as discussed in session 2. Reducing the risk of patient fall, risk assessment, prevention measure, and post-fall review needs crucial and thorough examination. Today we focus on goal 1, 3 and 6 as other remaining areas are covered in the remaining topics, plus the pressure injury and the restraints, which also essential in terms of NABH patient quality management aspects. The learning objectives of this video: by the end of this video you will be able to apply the two identifier rule using two identifiers for every drug, procedure, transfusion and specimen, and never using the room number of the patient, and use the Morse fall scale, score fall risk, apply preventable measures and respond to fall correctly. Using the Braden scale and PA staging, predict pressure injury risk, recognize the 4 stages of pressure injuries, apply restraint policy correctly, indications, types, monitoring, documentation, and how to minimize restraint use. Goal 1, the two identifier rule. Use two identifiers before giving any drugs or any blood, procedures, samples, imaging, meals every single time. The acceptable identifiers includes the patient's first name, the UHID or hospital ID number, the date of birth or the biometric when used. How to check? Ask the patient to state name or date of birth. Don't just read the wristband. Verify against the wristband. Match to the order, drug label, sample. In unconscious patient, check the wristband plus UHID. Family confirms when present. Never use as identifiers are the room numbers, the bed numbers, Mr. R or partial names, and physical appearance or the patient on ventilator, etc. The real world disasters: when we transfuse the wrong blood transfusion, they result in ABO incompatibility and result in potential death. The wrong patient surgery, it's a never ever happening or event to happen anywhere. The wrong patient chemo can also result in fatal side effects in a normal patient. If you skip these steps, you are gambling with someone's life. Morse's fall scale, IPSD 6. You should score this on admission, after a fall, on transfer, and per shift in high risk patients. History of falling, secondary diagnosis, ambulatory aid, IV heparin lock, gait, and mental status will be assessed as per the criteria and scored between 0 to 30 as given in this schedule. The total risk result in the risk and action plan. If the score is between 0 to 24, it is low risk, the routine care is essential. Between 25 to 50, it is moderate risk, standard fall precautions, and yellow wristbands. If it is more than 51, it's high risk, the high risk protocol, bed alarm, frequent rounding, and family education and restraints last resort. Note for ICU: most ICU patients score high on more safe. IV lines, mental status, weakness. The score is less for triage and more for documenting when you assist and applied fall precautions. The key ICU measures includes bed rails up and locked, bed in low position, call bell within reach, frequent rounding, family at bedside, footwear for ambulation, and post extubation supervision. Post fall response: do and use this sequence. A fall is a notifiable incident. NAVH 6th edition requires reporting, root cause analysis, and learning from it. So do not lift the patient immediately. Assess the airway, breathing, circulation, and GCS in place. If you suspect any spinal injury, log roll use when the patient is being moved. And check for injury in head, scalp bleeding or hematoma, laceration, and for limbs any deformity, pain, rotation and movement, length discrepancy as well, and for pelvis if there is any pain. Regarding the vitals, GCS and glucose, especially if witnessed loss of consciousness or new confusion. Check the blood sugar levels, especially in this case. Inform the doctors and nurse in charge. So residents see patient, decide imaging whether CT is needed or not based on the patient's anticoagulation status and the consciousness level. Reassess the MORSE and apply high risk measures. Score is now high regardless of previous score. Bed alarm, sitter, and frequent rounding is essential. Regarding the document and file incident report, time, witness, circumstances, intervention, family informed, time of escalation, and RCA initiated. Braden scale. The pressure injury risk. Most ICU patients are at high or very high risk. Reassess every shift. And sensory perception, moisture level, activity, mobility, nutrition, and friction and shear is being assessed between 1 to 4, except for friction and shear, which is between 1 to 3, as discussed in this slide. So total is equal to sum of 6 subscalables. If it is less than or equal to 9, very high risk, 10 to 12 it is high risk, 13 to 14 moderate, 15 to 18 mild, more than or equal to 19 is no risk at all. So most ICU patients score in the very high or high range. Pressure injury prevention is automatic, which is not optional. So ICU prevention bundle every shift. So reposition every 2 hours unless contraindicated. Heel offloading, skin assessment head to toe in each shift. Keep skin clean and dry. Pressure redistribution matters for high risk. Manage incontinence. Nutritional support like protein, calories, and hydration. And document the score and interventions made to prevent the pressure injury. In pressure injury, National Pressure Injury Advisory Panel classification. In stage 1, non-blanchable erythema of intact skin. Skin is intact but red, doesn't blanch when pressed. Stage 2, partial thickness loss with exposed dermis. Pink red wound bed may present as a serum filled blister. In stage 3, full thickness skin loss. Adipose tissue visible, slough or eschar may be present but doesn't obscure depth. For stage 4, full thickness skin plus tissue loss. Exposed fascia, muscle, tendon, ligament, cartilage, or bone. DTI, the deep tissue pressure injury, which is persistent, non-blanchable, deep red, maroon, and purple discoloration, intact or non-intact skin. And unstageable, the full thickness loss with obscured base, slough or eschar obscured the depth. stage only after the debridement. Regarding the restraints, it's a last resort, not first resort. The restraints are a clinical decision, time limited, monitored, documented, and patient rights applied. The rules before applying: try less restrictive measures first, like sitter, family at bedside, distraction, treat agitation causes, and review sedation. The doctor's orders required, time limited, maximum 24 hours, then reorder. Verbal order acceptance, countersigned within 24 hours. Informed consent for family. Explain the purpose, type, duration, document acceptance, etc. Use the least restrictive type. Mitten before wrist before 4 point. While in restraint, every 2 hours release and reposition. Range of motion exercise, skin cheek, look for pressure marks, lacerations, distal circulation, sensation, movement, etc. In every shift, reassess the need, can we de escalate, and doctor reviews and reorders, family communication. Documentation includes the type, time on, indication, monitoring, response, and time off, etc. And regarding the incident reporting and sentinel events, it's a just culture reporting. Focus on the system, not the person. What to report: adverse event, falls, pressure injuries, medication errors, including near miss, wrong patient, wrong site, wrong drug, wrong route of administration, transfusion reaction, adverse drug reactions, equipment failure causing harm, self extubation, line dislodgement, and etc. A near miss event or caught before reaching the patient. Report these, they are gold for system improvement. And sentinel events or never events or unexpected death or major harm. Mandatory reporting or root cause analysis. For example, suicide, a surgery on wrong patient, site or procedure, wrong blood transfusion like ABO incompatibility, retained surgical foreign body, infant abduction or wrong baby discharge, medication error causing death. And action includes immediate report to nurse in charge, quality cell, and RCA within 30 days. Findings shared, system changed. How this session maps to NABH 6th edition patient quality improvement. There are 6 points will be discussed here. The patient safety program includes hospital implements, a document patient safety program includes IPSGs, etc. And adverse or sentinel event management define process for identifying, reporting, analyzing, and learning from adverse events and sentinel events. Care of patients and restraints. The restraint use guided by written policy, time limited orders, monitoring, and family consent and documentation are crucial. International patient safety goals includes all 6 IPSG implemented: patient ID, communication, high alert medication, safe surgery, hospital-acquired infection, and fall risks. RCA root cause analysis includes tool for quality improvement. RCA for sentinel events mandatory. Staff training includes training in patient identification, fall prevention, pressure injury, and restraint use is mandatory. Key takeaways of this session includes 2 identifiers every single time. For example, name plus UHID or date of birth. Never use the bed number. Morse fall scale on admission after a fall on transfer. Most ICU patients are high risk. Braden scale every shift, reposition every second hourly. Heel offload, inspect knee, inspect the skin from head to toe. Restrain are a last resort. Doctor's order, time limited, and monitored second hourly, documented and family informed. Report all incidents, including near misses. The system learns, the patient is protected. NAB 6th edition Patient Safety and Quality 1G embeds all 6 IPSGs and they are now mandatory accreditation content. As usual, this is my MCQ page which contains 4 different MCQs. I would like to look at the answers in the comment section below. If you have any other questions, please ask, and thank you. Again, I will see you in the 6th session about ECG basics and arrhythmia recognition.